of Communications at the Washington Post and General Manager of Washington Post Live. Thank you all so much for joining us for our latest Chasing Cancer program. Today, we're going to hear from some of the top experts in the world of oncology on a number of topics, from the latest advancements in early detection to the impact that environment and lifestyle can have on cancer treatment and prevention. We're also incredibly thrilled to have Grammy Award-winning rock band Imagine Dragons here. They're going to tell us a little bit about their incredible nonprofit, the Tyler Robinson Foundation, which they founded in honor of a young fan who died from a rare form of cancer. And so before we begin, I'd like to quickly thank our presenting sponsor for this event, AstraZeneca. You're going to hear from them a little later this morning. And our supporting sponsor, the Johns Hopkins Kimmel Cancer Center at Sibley Memorial Hospital. So now I'd like to go ahead and get things started, hand things over to my colleague, Lori McGinley. She's going to lead our first discussion. Thank you.
Good morning. Thank you so much for being here. I'm just delighted to introduce my first panel. I'm Lori McGinley, a health reporter here at the Washington Post. Joining me are Dr. Douglas Lowy, Acting Director of the National Cancer Institute, Ellen Siegel, Chairperson and founder of Friends of Cancer Research, and seated next to me is Dr. Richard Pazder, Director of the Oncology Center of Excellence at the FDA. A reminder to everyone who is following this, we'd love to have you join in the conversation. And if you have a question for any of our guests, please tweet them to us using the hashtag #PostLive. So let's start with a few questions about cancer prevention and early detection. Dr. Lowy, your research led to the development of the HPV vaccine, which prevents cervical cancer and several other cancers as well. And yet the vaccination rate is still somewhat low in the United States. Could you tell us where things are and how to get the rate up?
Certainly, Lori. First, it is a pleasure to be here, and I really appreciate you and the Washington Post trying to highlight prevention and early detection of cancer in this particular session. I should also point out that I have never been the opening act for a rock band, and so it's really something. But getting to HPV, the uptake of the HPV vaccine has not been as optimal as one would have hoped or expected. But the current data, the latest results, actually are very encouraging in terms of the impact of the vaccine on HPV infection. In young women who are under 20, in the last 10 years where there's been measurement between 2006, when the vaccine was first approved, and 2016, there's been more than an 80% decrease in the prevalence of the HPV types that are targeted by the vaccine. So I think that we can look forward to substantial reductions in precancer, which has already been seen, as well as in the various cancers that are attributable to HPV infection.
So we've gone from 3 shots for HPV to 2 shots. Are you going to get us to 1 shot?
Well, thank you for asking. We actually have data from a clinical trial conducted in Costa Rica suggesting that one dose might be sufficient. But this is not enough to change standard of care, but we are in the midst of conducting another large trial in Costa Rica to test Gardasil 9 as well as the GlaxoSmithKline vaccine, Cervarix, whether 1 dose would be as good as 2 doses. And it remains to be seen. We are down in Costa Rica because they have the highest incidence of cervical cancer when the NCI first went down there. among women. So it's a very good place, and it also has an impact. While the NCI has been down in Costa Rica, the incidence and mortality from cervical cancer has gone down by about 50%.
When will you know the answer to whether we can go to one?
We expect probably 2024. It's a very big trial because we have good interventions, and so you're not allowed to have a placebo in that trial. And so you need to first vaccinate a large number of young women and then see whether or not they develop infection. So it will take probably another 4.5 years.
I'd like to ask you all what you're most excited about in terms of the advances in cancer over the last few years, where we've really seen a sea change in terms of the kinds of treatments that are available. Dr. Pastor, could you start on that?
Well, this year is my 40th year as an oncologist and 20 years at the FDA, so I have a lifetime of experience. And I started in oncology when there were about 30 oncology drugs, and now the number is, I can't even count the number of drugs what we have approved in the past 10 years, so to speak. But I think the major advances have occurred basically in our understanding of the mechanisms of disease and how our body fights against the disease. So we have targeted therapies specifically aimed at molecular targets on the neoplastic cells, the cancer cells, as well as a greater understanding of tumor and the immunology of these diseases. So we have a whole new class of drugs, such as the PD-1 drugs, and CAR T cells that really have had a tremendous effect on patients.
And these are drugs that target the immune system,
correct.
not
and
the cancer?
Correct, and they really act by turning your own body's immune system onto the cancer to make your body fight the cancer, so to speak, rather than conventional cytotoxic drugs, conventional chemotherapy that is directed at the tumor specifically.
And what do you see in the next 5 to 10 years, and what are your greatest concerns or frustrations about getting to where you want to go?
What I'd like to see is a greater, really, cooperation in the pharmaceutical industry of developing drugs, rather than a competitive spirit, which I think is important. There also has to be a degree of collaboration. For example, we have many PD-1 drugs that are quite similar. I would hope that companies would work together in the next generation of these immunological therapies rather than purely a competitive spirit.
Well, and I've seen you actually lecture and maybe yell at is too strong a word, drug companies about their tendency with immunotherapy to do duplicative trials and produce redundant drugs. What can you do about that? Because you don't order the pharma.
Well, there's only so much we could do at the FDA. We can't prevent somebody from developing a drug. We try to encourage clinical trials that will enable pharmaceutical companies to collaborate with each other, such as platform trials, such as the use of common controls, so they could get a common mechanism of testing drugs. But this is an area of concern because we don't need duplicative efforts. I have repeatedly stated that patients are not the resource of a pharmaceutical company. They really are a national resource, an international resource, and we have to be protective of that resource and use patients or their participation in clinical trials has to be done in a thoughtful way rather than just enrolling patients to answer a relatively mundane question.
Ellen, what about you? What have you been most excited about in the last few years, and what do you see going forward?
Well, first of all, I want to thank you for this forum today, and I'm honored to sit among heroes, Doug and Rick, people who have made a huge difference in the life of patients and have dedicated their entire life to cancer. So an enormous gratitude. What I am excited about now is that we're seeing curative therapies. We're seeing therapies that actually can cure people, and that's incredibly important. And also therapies now that are targeted for individual cancers. So those are really important things because before we were treating lung disease or breast, and now we know, we have a better idea of these targeted medicines because of the investment in research and because of what Rick has done at the FDA to get these treatments out to patients. but they're also less toxic. And also the patient voice is now very, very important. The idea of what is important to a patient. Patients all want cures, they want treatments that will help them, but they also want quality of life, and there are major changes, so I'm quite excited about what's happening. We still have a lot to do.
Dr. Lowy, what about you?
Well, first, let me just say that we still have many, many, many too many people who die from cancer every year. In the United States, about 600,000. On the other hand, we are making a lot of progress. It is hard to prioritize, but I'll give you three examples. And it's first, I would start with the treatment advances that both Dr. Pastor and Ellen Siegel have been talking about. But what I take away from them, in addition, is a change in attitude about cancer, an optimism that cancer is potentially treatable. We have the example of former President Carter, who 4 years ago had melanoma metastatic to his brain, and he got treated with one of the new immuno-oncology drugs, and now, just like every other 94-year-old, he goes and builds houses. You know, so a second area of advance is a very effective treatment for hepatitis C virus infection. This is epidemic in the United States. There's more than a 95% cure rate now from the HCV antivirals, and we really could, in principle, really dramatically decrease the incidence of hepatitis C virus infection. And the prediction is that if we didn't do that, the incidence and mortality from liver failure and liver cancer in the 2030s would go up dramatically. So this is another example. And then the third example is the enthusiasm among cancer researchers. At the NCI, we have, over the last 5 years, had a 50% in the number of grant applications for cancer research. This is about 10 times higher than all other areas of the NIH. And this, I think, is really a reflection of the optimism that the cancer research community has of the opportunities in cancer research. So those are three.
Circling back to where we started, can you tell us a little bit about what the efforts are, what you have learned from helping to develop the HPV vaccine, and whether there are other cancers that could be prevented by vaccines?
Sure. Well, the first vaccine was the hepatitis B virus vaccine, which hepatitis B virus infection is a cause of liver cancer, and this is really a big problem, particularly in Asia. And there we see in Taiwan already a substantial decrease in the incidence and mortality from liver cancer as a result of HBV vaccination. And this will now be seen worldwide. In addition, the principles of the HPV vaccine, which really are figuring out how to make a vaccine that has a very high immunogenicity rate, are being applied in other situations. For example, with Epstein-Barr virus, which causes a number of different cancers in the United States, but especially in Africa as well, the most common cancer of children in Africa, Burkitt lymphoma. And the use of a so-called repetitive structure is very analogous to what's being done with the HPV vaccine. That's research by colleagues in the Institute of Allergy and Infectious Diseases at the NIH, and the hope is to go into clinical trials sometime in the next few months. But that's just one example.
Laura, can I make a comment on this? Because this is obviously really, really important. But there are a lot of diseases that we have no idea how to prevent, intervene, and to treat. So while we have to, the gold standard is to prevent and early detection so we can treat and not have patients suffer. But there are over 500,000 people that will be diagnosed with cancer this year. Over 1 million will die, and many of them, we have no idea how they even get the cancer, blood cancers, glioblastoma. So we have to be careful, and we have to do prevention, early detection, but we can't stop treating patients who are being treated right now.
Well, that actually brings me to the next thing I wanted to ask you about, which is there's a new book out by a Columbia professor named Dr. Azra Raza, who says that the current approach on cancer isn't working, that the drugs are too targeted to the very sickest, and that they focus, that they cost too much and they don't work all that well. And then she's calling for a major shift to prevention and early detection. Is she being too negative, or does she have a point, or somewhere in between?
Well, I'd like to answer that, okay? And I think people, and I'd like to follow up with what Ellen has just said, because I completely agree with it. Prevention is obviously an important issue, okay, but we have to understand that we also have patients and a population of patients that have advanced disease, okay, and they do require treatment. The other very important thing is that although drugs are tested frequently initially in a very advanced population where the response rates, where the efficacy may be rather modest, they quickly go into earlier stages of the disease where their effects are greater, as well as going into the adjuvant therapy and the neoadjuvant, treating patients that are at high risk after curative therapies that may have relapsed, okay? And these offer a chance of cure, for example. So, you know, I look at this as more as a continuum of drug development rather than basically saying that there's prevention here and basically the treatment of advanced disease. I think it's also important to realize that we really have to address people's problems that are here at our doorstep, so to speak. I think that echoes what Ellen has
Ellen,
pointed out.
how does the patient view this?
Everybody wants to prevent cancer or wants treatments that are curative. However, that's not the real world. In the real world, where people are being diagnosed, many times we have better treatments that are personalized, that are better for treatments, and their chances of responding are much higher, thanks to the bravery and what Rick Pazder has done at the FDA and what the basic research and what has happened at the NCI. But patients want a treatment that will work. They want a treatment that will work for them. They're very interested. They're not just getting lung cancer or breast cancer, they're getting specific genomic diseases or getting tested. They want their best shot, and they want to live, and they want quality of life, and they want to know options, because it's not all the same. You know, we used to treat lung cancer, we used to treat breast cancer. It's different now. So they have to have the best opportunity for them, because they all want the same thing. They want to live, they want quality, and they want to be with their families and be productive, and they don't want to suffer during the treatment.
Dr. Pazder, could you talk a little bit about the whole debate that's going on about using expedited procedures at the FDA to approve cancer drugs? And there are many people who applaud it and are very happy about it. And then there has been some criticism that maybe, as I mentioned before, the drugs are not as effective. And I'm just wondering, how do you feel about that when you hear
well,
that?
Well, I'm working on an article, and the title of the article, which kind of summarizes my thoughts on this, is When Science Collides with Drug Development, the Need for Regulatory Flexibility in the Area of Precision Medicine. And I think what this echoes is really we have to be realistic that the measurement of overall survival, which many of these people want, basically, simply is not possible always with the development of oncology drugs. And there are many reasons behind this. We're having smaller and smaller subpopulations of patients based on genetic markers, which just makes it impossible to do a survival study. Many times the natural histories, as well as the histories due to therapeutic interventions, are now very prolonged. So to get the answer of an improvement in overall survival may take decades to really demonstrate, or many, many years. And also the lack of equipoise in clinical trials. When we go into a randomized trial, frequently we have additional information preceding that started the randomized trials. And people, when they know a particular therapy may have a much higher response rate than conventional therapy, will not want to go on a clinical trial.
So there's a lack of equipoise.
There's a lack of equipoise there. And we've had many discussions over the years with patient groups, and they look at other endpoints also of being benefit. For example, when a tumor shrinks by 50% or by 30%, whatever, people view that as benefit to them. That's how oncology is practiced in the real world. When you have a rapidly progressive tumor, and that tumor is then, the progression of that is delayed, people would consider that of benefit to the patients. So I think as we get into a very dynamic environment where many oncology drugs are being developed and really the natural history of many diseases are changed, we have to demonstrate the appropriate degree of regulatory flexibility. I always say the purpose of the FDA is really to guarantee that we have safe and effective therapies going out to the patients. It's a government agency responsible to the patients, okay, not to the preservation of a p-value in a statistical analysis, so to speak. But really it has to be geared to what the patients need at a specific time. And that degree of regulatory flexibility has to be there in an area where we're seeing a rapid progression of science.
I feel strongly that I need to react to that. First of all, these critics are not understanding science and nor the patient needs. When you have a disease with an unmet medical need, you're not going to wait 10 to 15 years till it's perfect. You have to get these treatments that are likely to help you, and if one doesn't help you, have another. Many of these patients are living 3 to 5 years. They're seeing their children graduate. They're seeing birthday parties. They're doing things with high quality. They're going back to work. No patient with a diagnosis of cancer, particularly one of these deadly ones where we really don't have effective treatments, is going to wait for a p-value or survival benefit that may take 10 years. So they want treatments that are likely to work for them, and FDA is putting out treatments that are likely. They have standards. There is a standard of safety and efficacy. They're not just putting drugs out there that don't work. Now, many of them don't work as well as we'd like to, but many of them are working, and patients are living longer, and they're living longer with better quality life, and that's a really important thing.
And we've heard this repeatedly from patients that are facing advanced disease, that they're willing to take a risk here. Okay, and it's not going to be perfect all the time, and that's why some of the drugs come off, but they're willing to take that risk, and it's a joint risk that we share with patients.
I'd like to ask you a little bit about the elephant in the room, which you are not responsible for, but it still, I assume, affects you, which is high drug prices and high cancer drug prices. Dr. Lowy, how does it affect you? Does it affect you, how you do your job?
Well, our primary responsibility is to try to develop evidence for new interventions. And we specifically don't set drug prices. On the other hand, if we make advances which paradoxically increase health disparities because those advances are not available to all people, this really is a societal issue which needs to be dealt with. And clearly there's just been so many high-profile issues of with many suggestions of how to try to deal with the high cost. And at the risk of making things even worse, where I see the future is we're going to be having combination drug treatment, and combination treatments with 2 or 3 expensive drugs will make things even more complicated than with one.
Well, that's interesting because we are seeing some increased disparities in patient access to some of these therapies, especially, for instance, on something like the CAR-T therapies for blood cancers. There are issues about how much Medicaid will pay, how much Medicare will pay, and that's causing some problems among patients in terms of patient access.
Certainly, the issue of financial toxicity, bankruptcy, et cetera, are problems that are front and center with far too many patients who have cancer. You know, the dictum, your medicine or your mortgage, you know, as a dilemma is something that really is very unfortunate.
Dr. Pastor, how does it affect you, or does it affect you?
Well, we don't make decisions based on cost, okay? In fact, I really have no idea as far as the exact dollar amount that the drugs are going to be marketed at when we approve a drug. So we're somewhat agnostic to the issue of, in making a regulatory decision, the cost of the drugs. We simply look at safety and efficacy. Nevertheless, this is a major problem that's facing oncology. Does anybody have the answer to this? I don't think anyone has the answer to it. I think it really requires a continued discussion about what are the value of comparing different drugs in a different setting. I think that's a very important issue. But these become very complicated issues because none of the drugs have the exact same clinical trial. They frequently fit niche patient populations. So it's a very difficult question to answer. But from a regulatory point of view from the FDA, we're not looking at cost when we make a regulatory decision.
Ellen, how did you get involved in cancer advocacy, and how has the field changed over the last several decades?
Well, my story is a personal story. My sister died of breast cancer at 40. She was diagnosed at 32. And she died of a bone marrow transplant, but she had metastatic disease. And I will never forget going home. She was treated in North Carolina, telling her 4-year-old daughter that she would never see her mother again. So that was extremely painful. We were very young and young children, and it was horrible. And I did what most people do. I started getting involved in raising money for cancer research at Duke and other places. And then I realized quickly that this problem isn't going to be solved at one place. It really needed a foundation and support for basic research and for translational research. And I served on the board of the National Cancer Advisory Board for 6 years, and Rick Klausner, who was the director at that point, asked me to form Friends for 1 year, and I said, well, what do you want? And everybody who knows Rick Klausner would say, he said, I want 300 things. I said, no, tell me one thing you want. And he said, well, we need funding for research. I did this now, it's 23 years later. However, I understand now that basically the research and the foundation is urgent, but if it doesn't get to patients, and if it doesn't help patients, it doesn't work. And even the drug pricing, which is a huge problem. The prices are too high, and patients are not getting access. But what we don't want is to stop the innovation and the precision medicine. What we want is not cheap drugs that don't work. We want drugs that will work for the patient on the first time they get it. That's the continuum. So the advocacy that we have at Friends of Cancer Research is really about regulatory innovation, but we don't want things on the market, and thank God for Rick Pastor and the people at the FDA. They're not putting things on the market that don't work. There has to be a standard, and we have to get them out to patients, because if they're not out, they're not getting access, and often they're getting ineffective treatments.
Dr. Lowy, is it true you wanted to be a football player? Is that right?
This is actually true. When I was in high school, I was a linebacker, and my dream was to actually be a quarterback. There were two problems that I had. First, I didn't have talent, and second, I didn't have size. So I ended up doing cancer research instead. And I don't know, I think I'm much better for it, thank you.
It's okay.
The world is better for it.
And Dr. Pastor, you've talked sometimes about your wife and her experience with ovarian cancer and how it's affected you. Could you talk to us a little bit about that?
Well, my wife succumbed to cancer about 4 years ago in November. And really that experience was a really devastating experience, as one would imagine. I met my wife on my first day of my fellowship in medical oncology. We were treating a patient with ovarian cancer, her and I. She was a nurse practitioner at that time in Chicago, where I was doing my training, and it's so ironic that she then developed ovarian cancer later on in her life. The story is one that is very different when you are an oncologist and have a knowledge of the disease. Both my wife and I had a thorough knowledge of what the natural history of the disease was. I frequently stated, it's like knowing the book, the story of the book, seeing the movie and seeing a movie that you had seen before, because you know what the end result is going to be.
And that you don't want to be at.
You don't want to be in that movie, so to speak. But I think the appreciation that is given me is on drug toxicities. It's a much different thing about seeing toxicities written on a page, grade 4 toxicities, grade 3 toxicities, rather than actually experiencing those toxicities. It's much different seeing the toxicities evolve in front of you, going to the emergency room, where the emergency room staff knows you on a personal basis because you've been there so long or so many times before. The other thing that it really emphasizes is what we don't teach in oncology very well, and that is the process of end-stage disease and also the aftermath of cancer on the family, and that is the process of grieving. I never saw that addressed in medical school, and having had to experience it myself was a very poignant aspect of my life and is one that I continues to experience.
Do you think they're teaching it now? Do you think that has to?
I think it's better, but I don't think it is really the optimal experience that anybody gets. Perhaps one has to live through it really to understand the full impact on one's life.
Well, thank you so much. Unfortunately, we're out of time. I could sit and talk to you all day, but thank you very much for coming to our conference. The next panel will be headed by my colleague, Paige Cunningham. Thank you. Please stay seated.
Policy reporter here at the Post and author of the Health 202 newsletter. And we're going to talk about some of the lifestyle factors that can increase or decrease your chances of developing cancer. With us, we have Dr. Ann McTiernan, an internist and epidemiologist at the renowned Fred Hutchinson Cancer Research Center, and Dr. Mikhail Varshavski, a primary care physician at Chatham Family Medicine in Chatham, New Jersey. Dr. Mike is also a popular YouTube host whose videos focus on health. Thank you for being here with us.
Thank you.
Thank you.
I want to remind those of you watching, we're eager to have you join our conversation. If you have a question for any of our guests, you can tweet them to us using the hashtag #PostLive, and I will relay them throughout our discussion. Let's talk about colorectal cancer first, because we know that incidences are rising among young Americans. And some experts are pointing to lifestyle factors like poor nutrition, lack of exercise as the reason. Dr. McTiernan, what do you think?
I think we don't know yet why the rate is increasing in younger people, but it certainly could be related to lifestyle. For example, we have an obesity epidemic, and obesity is related to increased risk of colorectal cancer. So we have people drinking alcohol, and that also increases risk of colorectal cancer. We don't know exactly, but we do know there are things that people can do to reduce their risk.
Let's zoom out for just a minute. Obviously, many different kinds of cancer. What do we know about the types of cancers that are most affected by lifestyle versus cancers that may not be as affected?
Yeah, it seems cancers of the gut, so we're talking about the colon, the esophagus, the stomach, those seem to be the ones primarily affected. Then when we're talking about skin cancers with sun exposure, and then any kind of air exposure, if we're talking about asbestos, smoking, lung cancer would be the next one. McTiernan, if you...
Yeah, no, I think you covered it pretty well, but surprisingly, some other cancers are showing up being related to these lifestyle factors as well. They may be less common, so they're not studied as well. But I think the main thing for people to think about for prevention is that things that they can be doing now could prevent a number of different types of cancer.
So one of the big lifestyle factors, obviously, is diet. Dr. Mike, what are some foods that you would recommend to patients that could reduce inflammation and potentially lower their risk?
Yeah, diet and cancer risk is a really interesting field of research because right now, the way we do research when it comes to nutrition is mainly observational studies. This is one of the lowest forms of evidence that we have in medicine. So our evidence isn't great. The things that we found is basically what grandma told us. That we should be eating our vegetables, our fruits, foods that are high in fiber, and whole grains. Those seem to have the best evidence. If I'm recommending a diet, I would say eat a diet rich in those foods and then limit processed foods like the bacons of the world, the sausages of the world. And then there's some evidence that exists as well that is not as strong as the ones that help with red meats in terms of colorectal cancer risk.
Dr. Maternian, there's been some recent research about red meat. Can you explain that for us?
That's right. Well, there's been research going on for years in this area, and several groups, such as the World Cancer Research Fund and the World Health Organization, have looked at this carefully. And the World Health Organization classifies processed meats as a carcinogen, as the highest level of carcinogen. And that just means the evidence is there that if people eat a lot of these, they can increase risk of especially cancer of the colon and the rectum. There is some definite evidence that red meat also can increase risk. It's not as strong a carcinogen, but the main thing to think about is what is a serving size? A serving size of meat is considered about the size of the palm of your hand or a deck of cards. And for a lot of patients, a lot of people, that's not what they're eating. They're eating much more than that. So if we give a recommendation to keep your serving size to about 3 servings per week of red meat to keep your risk low, that doesn't mean 3 huge platterfuls of steak. It means a portion size, yeah.
Because I think a lot of people are being encouraged to follow that type of diet given the popularity of the low-carb, high-fat diet. Does that trend concern you at all?
It's something that's a lot of new research is being done on, like the keto diet is a huge thing people on social media ask me about all the time. And what we see is there's different results when people don't consume carbs but consume high amounts of fat and protein. The outcomes of that in terms of cancer risk haven't been as clear when I look at the research. So we've seen some cancers that feed primarily on glucose have lower rates, but other cancers have higher rates. So to say that following, let's say, a keto diet is good for a cancer patient, I wouldn't necessarily go that far. I don't think the research has shown that yet.
Okay. And then when we're talking about increased risk or less risk, how much are we talking about? Because I think it's really easy for people to look at these recommendations and sort of extrapolate that if they eat this or that food, they aren't going to get cancer.
Mm-hmm. It really depends on what you're looking at and what cancer you're looking at. So for something like processed meat, each portion of about the size of a hot dog increase, if somebody's having that per week, then that increases risk by about 20%. So that's for people that are regularly eating that. But for something like obesity, somebody who has obesity may be at risk for increased risk for breast cancer after menopause, so about a 30% increased risk. But they might be at double the risk of endometrial cancer, might be at 50% increased risk of colon cancer. So it really depends on the cancer and what exposure we're talking about.
I also think that when we look at the numbers, we see that 30 to 50% of cancers are attributed to preventable factors, whether that means dietary habits, exercise habits, avoiding bad habits like smoking, over-drinking alcohol. And then there's one that's sort of less looked on by the general public, and that's getting adequate rest, which I don't mean just sleep. Yes, we need 7 to 9 hours of sleep because if we don't get that, it has tremendous impacts on your health, primarily on your immune system, which actually fights against cancer. But the next one is mood. If we're constantly in a stress state, the mind-body, and it's one word, it's not mind and body, the mind-body connection actually ends up harming your body by increasing the amount of certain hormones like adrenaline, cortisol, increases the nervous system that's the fight or flight response that we know to be the sympathetic nervous system. And when that happens, you don't have the proper processes going on like rest, digestion, absorption of nutrients, healing. And when that doesn't happen, you have increases in cancer risk that people are surprised to hear that this even has an impact on their health.
What kind of recommendations do you give to your patients then along those lines?
So I talk about frequently the 3 pillars of health, and that's nutrition, exercise, and sleep. The sleep one is the one that people feel they can skimp out and think that it's not going to affect their health. I frequently hear people say that they can function on 4 or 5 hours of sleep just like anybody would with 8 hours. And one of the leading researchers from UCLA, Matthew Walker, stated really well that if you round to the nearest whole number, the percentage of individuals who can function on 4 hours of sleep and still be healthy is 0. So to think that sleeping 4 or 5 hours a week on a day or a night on a consistent basis is going to yield good results, absolutely not. Your creativity, productivity, your cancer risk, your immune system, everything is going to suffer across the board. So I encourage rest. But then the second part.
But just on that, what if you catch up? What if you catch up on the weekends? So say you get 4 or 5 hours during the weekend, and you sleep for like 8 or 9 hours. On the
Is that your secret?
I wish. I have kids, so
Okay,
no.
got it. Catch up works to some degree, but it's not perfect. So napping helps, catching up on weekends helps, but it's really the consistency that's key. Getting the same consistent during the same hours of sleep every night is ideal. And then the other part of that rest is making sure that your mind is at rest. We talk about acute stress having good impacts on your health. Those types of challenges are good, whether it's to your immune system, your mental state. But then chronic stress is actually toxic to your system. When we're talking about cancer risk, if you're under chronic stress, which can lead to depression, 3 things happen. A, you're more likely to engage in unhealthy habits like smoking and drinking. 2, you're less likely to seek help and visit a doctor and get all these tremendous screenings and vaccinations that actually prevent cancer. And then 3, because of your mood, your sympathetic nervous state is elevated, so not enough healing happens, and that also increases your cancer risk as well.
Let's talk about exercise for a minute, too, as another factor. And it's been interesting. There's been a lot of chatter recently about how, you shouldn't rely on exercise so much for weight loss per se, but how does that affect your chances of developing cancer?
Well, exercise helps with a little bit with weight loss, and long term it helps keep weight off, and it really helps prevent weight gain, which is one of the problems. Most people become obese by gaining weight over their lifetime. But exercise might have some effects on its own, even beyond weight control. And we've seen in the large studies that exercise reduces risk for several cancers, like breast cancer, colon cancer, bladder cancer, stomach, endometrium. So a long list of cancers that are associated with a lot of these lifestyle factors.
I think if we put the health benefits that you mentioned from exercise into a pill, where we say this pill decreases cancer risk, increases longevity, boosts mood, sexual, cognitive performance, people would pay billions of dollars for this. If I created it, I'd win the Nobel Prize, yet it's very difficult to convince my patients to begin an exercise program.
How intense do you think the exercise should be? Are we talking about walking? Do you need to run a marathon every day?
Yeah, this is age dependent, but our sort of standard recommendation is 150 minutes of moderate intensity exercise per week.
Okay. Let's talk about alcohol for a minute, because younger people are drinking more. It's very popular. To enjoy a glass of wine with dinner. Cocktails are very popular. But what should people know about alcohol consumption and risk of cancer?
Right, alcohol and the consumption has gone up. Part of it is people can afford it more, and part of it's social. But alcohol use does increase risk for several cancers: colorectal, breast, esophagus. Again, I could give a long list of things, but there's definitely association of increased risk. And alcohol is also listed as a carcinogen by the World Health Organization. So the goal there is, even if somebody chooses to drink, to really moderate how much they're drinking. And the guidelines for most health organizations are saying 1 drink a day for women, 2 for men. That's something where we don't have gender parity. Women tend to metabolize alcohol different than men, and they can't handle as much. So that's why we're supposed to keep our intake lower than the guys.
And something I've noticed that some of my younger patients do is when we give a recommendation like this, where we say 1 drink a day or 2 drinks a day, depending on your gender, they say, okay, well, that means 7 a week or 14 a week. So I'll do that on the weekends. I'll have 7 tonight or 7 tomorrow, and that's binge drinking. And when we're doing that, we're actually increasing risks of not only cancer, but other illnesses. And myself as a family medicine provider, I think cancer foremost in a lot of these cases. But we also have to think about cardiac deaths, obesity, making bad choices when you're drinking alcohol. So really, when you're overindulging in alcohol, there's a lot of bad effects that happen, and they happen in a dose-dependent relationship. So the more you drink, the worse all of these outcomes become, including cancer.
Have we seen any differences between, say, drinking a glass of wine, which we know can have some health benefits, versus other types of alcohol? Or is it just alcohol
Not
across
in the
board?
data. It's,
Okay.
it's across the board, yeah.
Okay. Dr. McTiernan, you also study chemoprevention, which is the use of medications, vitamins, or supplements to reduce obesity, inflammation, other cancer risk markers. Are there healthy supplements out there that people can take to reduce their risk?
We usually say that for cancer prevention, rely on natural foods. You don't need to be paying a lot of money and taking a lot of supplements. There may be some people that have deficits, and that's something to work on with your doctor, your family physician, your internist, and then talk about what might be appropriate for you. But just walking to a store and getting huge bottles of these things and taking them every day or however often people do, there's no known benefit to those in terms of reducing risk of cancer.
Just to sort of piggyback on that, I love that you said that, because myself, I'm on social media, I make YouTube videos, and a lot of the questions people have are about supplements, because there's so many false promises made, whether we're talking about essential oils, vitamins, miracle cure-all products that are peddled online. And with social media and the current algorithms, it's really become a misinformation superhighway. That's why I really advocate for doctors who are evidence-based physicians to come on social media and battle this misinformation. Frequently we talk about the vaccine misinformation epidemic that's happening on social media. But cancer risk reduction and miracle cure-all products are actually a big problem. In fact, I encourage everyone in this room to do this after this conversation. Open your phones and type into Google, curing cancer with, and then stop typing. The #1 recommendation is going to be curing cancer with carrots. I'm not joking. And this type of, and it's solely based around one person's experience who had stage 4 colorectal cancer, started drinking carrot juice in obscene amounts, and quote unquote cured her cancer. Now this type of misinformation misguides our patients away from proven treatments, proven cures, and essentially yields worse outcomes. So I think we need to be honest, get quality doctors on social media, and try and amplify their message as best we can.
Well, right, to your point, you know, many of us know people who have followed very healthy lifestyles, and yet they still develop cancer. What do you say to those people?
I'd say it's kind of like wearing a seatbelt. So if you wear a seatbelt, you're not guaranteed to avoid injury, all injuries in a car accident, but it certainly reduces your risk. So it's the same thing with lifestyle. If you eat a healthy lifestyle, it's going to reduce your risk for several diseases, you know, not just cancer. And it might make you feel a lot better as you go through your normal day. You have a lot more energy if you're sleeping well, exercising, and not overeating things that can make you feel kind of sluggish.
As you have learned about lifestyle factors, what individual decisions have each of you made in your own lives, whether that's diet or exercise or other things?
Well, being a person that's trying to do a lot of simultaneous tasks, like be a doctor, be on social media, do television, sleep is obviously difficult to come by. But I made it a rule that the minimum amount of sleep I'll get is 7 hours. And in the worst case scenario, it'll be 6, which I got last night, so I cheated a little bit. And I really say, if I'm going to recommend this to my patients, I have to live by that mantra. So I really try and put in that 7 hours of sleep no matter what I'm doing.
Dr. Tierney?
Yeah, I'd say I exercise. I follow my own prescription for exercise, so I make sure I do a lot. I'm not an athlete, so I just go out and walk with friends or my husband. I do some strength training, I try to keep my calorie intake low so my weight doesn't inch up too much over the years. I follow the alcohol recommendation also, and then I try to get enough sleep, but these things are hard, and for some people at different times of their life, many of these lifestyle factors can be very difficult. But there are many things that people can fit into their lives, even if they're a challenge.
There's another factor here, so environmental factors. I know we talked a little bit about this, Dr. McTiernan, but can you kind of lay out what some of those factors are and how people can avoid them?
Well, some of the things we talked about, I'd say avoid carcinogens. And so some of the things, the food, like processed meat or alcohol. possibly things that in cosmetics. We hear in the news about things that are in cosmetics, that asbestos may be in makeup, for example. So I think just watching what's happening there. Another potential is talcum powder products. These are carcinogens, and they can cause ovarian cancer and perhaps other cancers. So I'd say to just be careful of what things you need. There's some things people are going to need in their lives, or they're going to be very difficult to avoid, but some things that they can make choices about.
I've got a couple Twitter questions. Alex wants to know, do mental health illnesses increase your chances of developing certain types of cancer? Dr. Mike, that's a good question for you.
Yeah, I don't think we have quality research to give a definite answer on that. I think I can give sort of an expert opinion on it, which, by the way, is the lowest form of evidence. So whenever a doctor says that, please take it with a grain of salt or sugar, whichever bad nutrient we're talking about. I think that it would, unless they're being adequately treated. So if you have someone that's suffering with mental illness and not getting treatment for it, that's again going to lead them down the hole of having bad habits, not seeing their primary care doctor. And how do you change your lifestyle when you're so focused on your mental illness? How do you exercise when you're hallucinating? How do you eat healthy when you can't even get out of bed? So I understand what these patients are going through. This is something we deal with. But if you're seeing a quality mental health professional, a quality family medicine doctor, I think there are ways to get around those hurdles and maybe not impact your cancer risk away from the average population.
Okay. One more Twitter question. Pat wants to know, how does vitamin D deficiency affect the risk of developing certain types of cancer?
The observational studies, again, suggest that vitamin D, people who have very low levels might have increased risk of some types of cancer, like colorectal cancer. But when trials were done, that it's not clear that supplementing to a certain point is going to reduce your risk of cancer. I think the main thing to be concerned about for vitamin D is, are your levels extremely low? And that's something a doctor can check pretty easily. You don't need to be checking you don't need to check a lot. You could do once or twice, and then maybe you might need some supplements. The problem is humans used to get vitamin D through the sun, and now we know that sun exposure increases risk of several types of skin cancer. So we recommend that people use sunscreen and cover up in the sun to avoid that cancer, but then the vitamin Ds might be lower. So I'd say check with your doctor, see if you need it, and I wouldn't say take it otherwise. No.
Dr. Mike, cancer has personally touched your life. You lost your mom to the disease. Can you tell us a little bit about that and how that affected your advocacy work?
Yeah, so when I was a medical student, in my first year, I actually lost my mom to leukemia, which was a difficult situation to find myself in because the pressures of going through medical school, losing a mother. We just came from Russia at that point, I believe 8-9 years ago, and my family was just finding their way. My father went to medical school a second time in the United States, did residency for a second time in his 40s in a new language, finally getting on his feet. So to lose our mother was a very difficult journey. From that, I'm better able to understand what my patients are going through, better able to empathize with them. And it's made me more passionate than ever to talk about cancer. I've worked with Stand Up to Cancer, Susan G. Komen Foundation. Any way I can get research dollars, attention, notoriety to the causes that drive cancer cures and research, I'm going to put all my effort into that because there's too many amazing folks that are losing their lives or getting tremendously affected by cancer.
Well, unfortunately, we're out of time for this segment, but thank you both for being here. I'm Paige Winfield Cunningham, and we'll be back with you a little bit later in the program. Please stay seated for our next segment.
Hello, ladies and gentlemen. On behalf of AstraZeneca, I'm excited to be here at the Chasing Cancer Summit. My name is Adrian Kilcoyne. I am the medical lead for oncology here for AstraZeneca in the United States. And why are we here? Well, this time last year at the Chasing Cancer Summit, we introduced a program called Your Cancer. So what is this program? This program, which we're very proud of, is designed to really shine a spotlight on key individuals and organizations that are at the forefront of cancer care. But it serves another function, and that's to enable collaboration. At AstraZeneca, we acknowledge that an individual, an organization alone cannot defeat cancer. But if we collaborate across the academic, the cancer community, we believe we can do much more. We can amplify our efforts. And to that end, that is why we're here today. Today, we want to focus on precision medicine. And for that, we have three leaders from three incredibly important institutions and organizations who are going to talk us through their insights, their view on the importance of precision medicine. Beside me, I have Cynthia Benz, who's the Senior Vice President of Public Policy at the Personalized Medicine Coalition. Now, the Personalized Medicines Coalition is a very important organization that has really sponsored a lot of investment in and adoption of personalized medicines, and we really look forward to your insights, Cynthia. Thank you for being here. Besides Cynthia, we have Andrea Ferris, who's the President and CEO of Longevity. I think it's not an overstatement to say that longevity has been key to the advances in lung cancer over the past few years. Not only through your investment in primary research, but actually, I would consider more importantly, your empowerment of patients to ensure they're involved in their treatment decisions. So thank you for being here, Andrea. And at the end there, and last but not least, we have Chad Ramsey, who's the Vice President of Policy at the Ovarian Cancer Research Alliance. Now, a little bit about that organization. They're not only the oldest, but also the largest ovarian cancer charity. And the work that this charity has done in lobbying at Capitol Hill has resulted in hundreds of millions of dollars being invested in ovarian cancer research. So thank you for the work you do. So Cynthia, I'm back to you. You're the first one to get a question. You have an unenviable task, but also a very important one in that you oversee all cancers. Mm-hmm. So maybe you're a good person to really explain to us why a personalized approach to cancer is so important.
Well, thank you, Adrian, and I'd like to thank the Washington Post and the sponsors for the opportunity to be here. The Personalized Medicine Coalition is actually made up of 230 member organizations from 14 different sectors of the healthcare spectrum, including patients and patient advocacy organizations. And one of the things that I think has been really a driving force for the Personalized Medicine Coalition over the years is that, one, we do support innovation both in the diagnostic and treatment space, but we also make sure that we've come together and our sole purpose is to make sure that there's access to those diagnostics and treatments to patients. PMC really came up at a time in the early 2000s when there were a lot of skeptics even within industry that personalized medicine and targeting smaller subsets of populations of patients through biomarkers would be the future of healthcare. So it took some convincing that this coalition should even come to be. At that time, 10% of the clinical trials had biomarkers in them. And I'd like to say that we've sort of looked at FDA's drug approvals for personalized medicine as a proxy for how we're doing in delivering targeted treatments. For the last 5 years, actually over 20% of all of the new drug approvals at FDA can be considered personalized medicines, and most of those have been in oncology. But just last year, over 42% were actually considered to be personalized medicine, and that's extraordinary. But what's more important is that about 55% of all clinical trials now, in oncology in particular, include some form of a biomarker. So if you think of where we were in the early 2000s, we've come a long way, but that's put an even more important emphasis on regulatory and reimbursement challenges that we all need to face as a community to make sure that the right patients are getting the treatments they need and getting put on those treatments that are going to save them time and ultimately improve their outcomes.
Thanks for that, Andrea. And What do you think? I mean, you say we have lots of personalized medicines, but of course for that we need a test. What are the gaps currently in patients having access to these medicines?
I think it's twofold. The first is making sure that regulators and the payers are actually keeping pace with the state of the science, and also that the providers are keeping up with the science as well to make sure that those treatments are ordered, and ultimately that's driving the right treatment strategy for patients.
That's a lovely segue into you, Andrea. We talk about keeping up. I think it's fair to say that lung cancer has been at the forefront of personalized medicine, and it has resulted in huge improvements in patient survival. However, as you may have alluded to, Cynthia, there's been, we call it an explosion of new medicines coming to market. And I would like to get your insight through your Take Aim program. How is the environment keeping up with the paces of scientific advancement?
Thank you. Thank you also for having me here today. And to piggyback off of Cynthia's question, I think that the scientific advancements are accelerating at an unprecedented pace. Just to put it in perspective, in lung cancer, there have been more drugs approved in the past 3 years than in the prior 15 years combined. It truly is a complete transformation of a disease which historically had been seen as one of no hope. It was very fatalistic. You're diagnosed, you were told to go home and get your affairs in order. And now it's a disease that's at the forefront of precision medicine. We like to say actually precision care, because I don't think it's just the therapy. It's really the whole continuum of care, as Dr. Pazder had alluded to earlier, where I think your biomarker can help dictate what happens and what your next options are or potentially aren't, because some of them, it could also tell you what not to do. But with Take Aim specifically, I think that that is emblematic of just sort of an approach that we need to take overall, where no problem is simple, right? Everything is, it sounds really easy. Oh, educate patients about the importance of testing or the importance of the therapy, but it's not. And so with Take Aim, what we did at Longevity is really, we brought together multi-stakeholders, it's a multi-year initiative, to look at what are those barriers that are preventing a patient or standing in the way of a patient diagnosed with, in our case, lung cancer, but really any cancer that's going down this path of precision medicine, from getting their tumor tested to know what then the appropriate treatment may or may not be for them. And so it turned into a multi-stakeholder, multi-year approach where there's a focus on education and awareness, but not just of patients, but of the providers, because there are many providers, particularly in community settings where they're non-specialists, where they're completely overwhelmed and they may not know of advancements. It's education and working on ensuring that a patient has adequate, the biopsy is adequate so that they can have enough of their tissue available to do all the testing needed. It's working with the pathologists and the labs to ensure that they're handling it appropriately so that they can do all the tests. And then there's a whole policy component. So I think that the science is absolutely outstripping regulatory, and Dr. Pazder had alluded to that as well, the reimbursement, the policy elements of it, as well as how healthcare is being provided. But I think that's why we all come together collectively as patient advocates to work together, compare best practices, and see how we can move the ball forward for everybody.
Well, thank you for that. Now, Chad, you work in ovarian cancer, and of course, it's a very specific type of cancer. It's got a well-publicized genetic component for some patients. And this creates an interesting challenge for us, because, and I'd like your view on how well you feel patients are equipped to understand the complexity, or if they even need to be equipped for this. I'd love your view.
Sure, right. Well, with ovarian cancer, we know that there's about 25% of the population who are diagnosed with ovarian cancer have a hereditary role in their cancer. And the problem is, far too people know that. They don't know their risk. There's an issue not only in knowing your risk, but also once you're diagnosed with ovarian cancer, not enough patients are receiving the proper testing to determine whether they have the biomarkers present, whether they have a mutation that would really help them in their cancer therapy. There are so many new therapies that have come on the market for ovarian cancer, just like with lung over the last 3 years, and almost all of them require a certain genetic mutation in order to be useful for a particular patient. And so the fact that genetic testing rates, genomic testing rates are so low is really problematic for even frontline therapies we're talking. So we think that there are a lot of issues in knowledge that patients have with respect to, well, should I have genetic testing? Should I have somatic testing? These are words that aren't really the first thing that you think of when you're diagnosed with cancer. You think, how am I going to beat this? What am I going to tell my family? You don't think, should I have germline hereditary testing, or should I have genomic genomic testing, somatic testing? So we have to do a lot as patient advocacy groups to help educate both the patient population and the provider population. We ought to streamline this process to make it as easy as possible for patients and providers to make sure that the optimal care is being provided. We can do the best possible job on approvals. The FDA can do a terrific job in getting medicines to market. NCI can do a terrific job of doing the latest research, but if patients don't have access to the best possible care, we're not doing them any good.
I think we would all agree with that. So Cynthia, I'm going to come back to you and ask you, we talk about the importance of collaboration with the oncology community. If, and I'll probably ask you all this question, if you had one ask for the audience and for the oncology community, what would it be?
I think it's the same ask that Dr. Pazder had during the panel this morning. It is true collaboration among stakeholders, and he talked about it in the context of looking at the development of treatments in the same space around the same biomarker. But I would argue when you're talking about targeted therapy, there needs to be quite a bit more collaboration even between diagnostics manufacturers as well as the pharmaceutical industries, and having that information sharing and innovation really bleed over into the healthcare system, and not for the folks who just live around major cities or on the coastlines, for people in middle America as well and in underserved communities.
That's a great point. And from the perspective of lung cancer, Andrea,
Well, I think it's lung cancer. We use lung cancer as sort of a case study for other cancers that are coming down this path as well. And I agree completely with Cynthia in terms of collaboration. But I think that one of the biggest things that we need to recognize, not just amongst our own communities, but is the importance of the advanced diagnostic and doing comprehensive biomarker testing, both at diagnosis and at progression, because it really does then dictate what you what will work for you, and ensuring that everybody has access to that. And I think that you had alluded to that in the Middle America, because not everybody has access to it and that it's reimbursed.
And Chad, the same question to you.
Well, I think one of the things that we're trying to do is make some changes through policy that will help improve the situation through education. There's a piece of legislation called Johanna's Law in the House that is a Gynecologic Cancer and Awareness Act, and it needs to be reauthorized. So Congresswoman Rosa DeLauro has just introduced that reauthorization. We hope to expand that program, improve on education at the provider and patient level. And we're also working on some legislation in the Senate to improve education for genetic and genomic testing, as well as create an additional benefit for folks to gain access to testing beyond BRCA 1 and 2.
Excellent, thank you. So we have about 2 minutes left, and I just want to, on behalf of AstraZeneca and actually on the wider oncology community, thank you three, as well as all the other organizations that do so much to improve the lives of patients and help us overcome cancer. Now, what I would like to talk about just for 1 minute is the UCancer and the importance of us engaging as a community. We believe that working together we can amplify our efforts. Our siloed approaches will not help us overcome this battle. But within this, there's also, within the field of cancer broadly, there are so many unsung heroes. And part of the UCancer program is an award system. So I would encourage everybody here today, and certainly you on stage, that if you have a peer, if you have a colleague who has really gone that extra mile and has made a huge difference for patients and for cancer care, please go to our booth that's in the reception area and actually nominate them. We want people to be awarded because we have so many unsung heroes in cancer. But as well as that, go on to yourcancer.org. It is a non-promotional site. It's all about building the importance of collaboration. But again, thank the three panelists for their amazing insights into this particularly exciting area. And with that, I would like to, again, thank the Washington Post, but I'd like to hand back to the Washington Post now.
I think of the times when he was having chemotherapy sometimes when he was the most ill. And Ty would go to this quiet place. He'd put his earphones on and listen to music. And his favorite band was Imagine Dragons, which was absolutely inspirational to him. And that was really important in his life.
For some reason, one of their songs that we loved had this line in it that just connected him and I. That line was, "The road to heaven runs through miles of clouded hell." And I remember telling him when it first came on, I'm like, "Tyler, that's it. That is exactly what I feel. Like, sometimes in life you have to go through the bad stuff to get to the good." So when anything difficult came up, it was just easy to say, "Hey, Ty, it's the road to heaven, man."
I don't know, but something was born in that moment. I felt a lot of sorrow, but I also felt like Tyler's legacy needed to live on because he had impacted me and he had a story to tell. And I called his brother that night, Jesse, and we cried and we talked and we laughed and we had this idea to start this foundation called the Tyler Robinson Foundation.
Good morning, I'm Paige Winfield Cunningham, health policy reporter here at the Post and author of the Health 202 newsletter. I'm honored and excited to introduce my guests. They are members of the Grammy Award-winning band Imagine Dragons. Daniel Platzman, Ben McKee, Wayne Sermon, and next to me is Dan Reynolds. So thank you for being here.
Thank you so much for having us.
The band has done philanthropic work for a number of causes, including LGBT youth, civil rights, and cancer awareness. In 2013, the Dragons started the Tyler Robinson Foundation, which is a nonprofit that helps the families of children suffering with cancer battle the many unseen costs of the disease. I want to remind, for those of you watching, we're eager to have you join our conversation through Twitter. If you have a question, you can tweet them to us using the hashtag #PostLive, and I will relay them. Dan, I want to start with you. Tell us about Tyler Robinson, how you met him, what is his story?
In the early stages of the band, when we were pre-signed, so we were still playing small clubs across the West Coast, Utah, Las Vegas, California, to rooms of about 200 people. We were still small enough that we were able to connect pretty closely with our fans, and I remember one day prior to a show in Utah that you saw a glimpse of, I got a message on Facebook from Tyler's older brother, Jesse. Tyler was 16 at the time. He had just been diagnosed with cancer and was going through chemo, and his brother basically said, you know, this has been a really hard thing for Tyler, obviously, in our family. But Tyler has been listening to your EP. We had, at the time, had just put out an EP with a song called It's Time, which ended up being our first single later on. And it had a line in it that said, "The path to heaven runs through miles of clouded hell." And he said, you know, every time he does chemo, he listens to this song, and it's kind of his song. And so, you know, tonight we're going to be at the show at the Velour, which is a small club in Utah. And so if you see us, you know, cool. You really didn't ask for anything at all. That was it. And so when we played that show that night, his brother kind of held him up on his shoulders, and it ended up being this really powerful moment, maybe the most impactful moment of our 10-year career. I can't really explain to you the magic that was in that room, but I'm sure it's something that other people have experienced when you go to shows and you just feel very connected to a group of strangers over a song. And I explained Tyler's story right before we played the song. And so then everyone saw Tyler and felt kind of this bonding, this kind of special moment. And we played the song, and you saw a glimpse of kind of what happened during the song. And I don't know, we just felt really connected to him. After the show, I got his phone number. We became friends throughout the years. Watched Tyler as he beat cancer and rang the bell, got close to his brother and his family, and then also watched when we found that Tyler had cancer again and then passed away. And
when was that? What year?
That was 2014, I want to say. He was diagnosed at 16.
Yeah, 14.
And
13?
I think. Somewhere around that. It's been a bit of a blur of 10 years for us. But I guess, I don't really know. Actually, yes, it was the night of, after he passed, that I called his brother. And we talked on the phone and said, what can we do to help Tyler's, impact and legacy live on? We had just signed, and he said, well, look, why don't we start a foundation together? And we said, okay, well, let's do it. We'd never done anything like that. Obviously, the four of us are not very professional at much but music. And so I called my manager, and we started the Tyler Robinson Foundation and asked his family, listen, we don't know what is going to be most impactful for these families. And they said, well, look, there's a lot of unforeseen costs that come into a family's life when a child is diagnosed with cancer. A lot of times a parent has to drop out from work. You have to change their diet. It can be a lot more expensive. And then on top of it, you have mortgages, you have all these car payments, you have all these things, and then you have, the average family, I think, spends $40,000. And over 15,000 kids are diagnosed with cancer a year, pediatric cancer. And so it's pretty devastating statistics. And so what we have done with the Tyler Robinson Foundation is we put together, we bring into a family's life, sorry, I know this is a really long answer.
No, this is great.
A financial advisor who comes into the family's life, helps them put their finances together, and helps them take care of all the unforeseen costs that come in with cancer.
Right, and when was this? How old is the foundation?
We've, how many years? 4 years?
We just had our sixth gala this summer. Yeah, and it seems to be doubling pretty much every year. I don't know if exponential growth is a sustainable, model to pursue, but fingers crossed.
Yeah. So can you describe, some more about, specifically what are you financing here? Because you mentioned there are all these unforeseen costs and sort of non-medical costs. But Ben, what are some of the specific ways that you feel like the foundation has helped families?
Yeah, there are a lot of federal programs that help people with finding medical costs specifically. So we try to help find ways to support them with getting transportation to their medical procedures. A lot of time people have to go out of state in order to find the proper pediatric care. A lot of times, somebody one of the parents will have to quit their job in order to be a full-time caregiver. And also a lot of times, these families, it's not just one child they have with cancer. They have 4 or 5 kids, and one of their kids has this diagnosis, and all of a sudden, every extra dollar they have and beyond that is sucked up into trying to pay for these medical procedures. So life is sort of just harder for the family all around. So we'll even go so far as to once a year we'll try to provide, the opportunity to just have Christmas presents or to be able to go on a vacation somewhere that they wouldn't otherwise be able to have to support, the rest of their family. But throughout the whole thing, we provide them with a personal business planner, a financial consultant that will go through and help them with all of their finances, so that after they're done with this ordeal, with this incredibly emotionally and financially draining process, that they're not completely left out to dry, that they haven't spent the resources that we've given them improperly and set themselves up in a really difficult place. We try to set them up for the life beyond the treatment.
And how do you identify which patients to help? Because I imagine you've there's any number of families that could use this type of assistance.
Yeah, we have, a process. We try to find the families that are not otherwise being supported by other programs. We try to find people that are above the poverty line because there are other programs that are supporting them below that. There are a number of ways that we vet the families. I'm not completely versed in every stipulation we go through, but we really try to find the way that we can make the most impact, the families that we can really, lift up and help to thrive.
Daniel, you guys are the main spokesman for the foundation. You recently played a big benefit concert at the foundation's 6th annual gala. Tell us about that event and how much money you raised.
Oh my goodness, yeah, the annual Tyler Robinson gala. I don't know if it's gala or gala. I mean, you're a professional. I'm
It's
gonna go
either
with
one.
you. Gala. The gala.
We gotta decide. Let's decide in this room right now.
I'll have to check the Post style book. I'm not sure.
No, you're the pro.
I'm a gala guy myself.
I used to be, but no longer.
Okay.
Tyler Robinson goulash.
Converted to gala. Okay. No, it was a smash success this year. The city of Las Vegas has really been an amazing partner with TRF. And this year we had a benefit with both the Raiders and the Golden Knights, the hockey team.
And Shaquille O'Neal.
And yeah, Shaq was at the gala. Oh, Shaq was
Dolph Lundgren.
Dolph Lundgren. Yeah, Ben has a photo with Dolph Lundgren and Shaq.
$3 million, right?
Yeah.
Check the gram.
3.2 or 3.5 million was raised this year at the gala due to the help of all those people we just named and more. The city really has gotten behind it. And we always do a very special, intimate acoustic performance every year. This year we had dancing children, and Shaq kept making requests, and it was a really special event.
Well, and you also had an experience recently where you played for some pediatric cancer patients at a hospital in Utah. Can you tell us a little bit about that experience? Any of you, really?
Wayne?
Go ahead. Oh, yes.
Okay.
Yeah, no, I mean, whenever we do that, it inevitably always feels so similar to that night Dan talked about all those years ago when we played for that show in Provo for 200-300 people. We've had the opportunity to share the stage with a lot of people. We've done a lot of cool things in our career. But that moment still for us that hasn't been surpassed. And so whenever we play for these kids, that same sort of feeling happens again. And it's a really special thing. And it doesn't happen often, so when it does, we try and soak it all in.
Yeah, I'm not a big believer in faith or fate or anything like that, but that night in Provo when we met Tyler Robinson really does feel like something. I mean, it was clear that something bigger than us was happening in that room that night, and it's something that has carried over into the rest of our lives and become the biggest, most impactful part of all of our lives. It's the most meaningful thing that we've been able to do is have this, be part of this foundation.
Yeah. It sounds like you guys are really unified on this cause, but obviously there are a lot of causes you could have rallied around. Was it hard to sort of decide that this is the thing that you all wanted to get behind, or was it that moment with Tyler that sort of unified you?
It was like a lightning bolt. It was clear that we had to do something. I remember that night, it was in Chicago, is when he died, and we all got into the car. We were playing the House of Blues. We were doing 2 nights in a row. It was between our first and second night. And we got into that car to do promo, and we all had a discussion, and it wasn't even a discussion. It was just, we need to make the phone calls and, get this happening.
Yeah, to know that the Robinson family created this really with us, and we aren't experts on what a foundation would do to help families in need, but they really are experts in if a foundation existed when they were going through this, what would it do? And that, I think that's my favorite thing about the Tyler Robinson Foundation is it's not stuff we came up with. It's the Robinson family really crafted this to help other families dealing with a pediatric cancer diagnosis.
And from day one, we had our financial planner, also our business manager, Jeff Schwartz, who was a cancer survivor. We called him. That was our first step, was calling him, because we had no idea what we were doing. And he immediately jumped on board and sacrificed so much of his time, so much of his effort, and gave so much of himself in terms of his time and financially to the institution. He actually just passed away this last year. He was we honored him at the gala this last year, but this would not have been possible without him and without Tyler and without Tyler's family. And it's just amazing to see the way everything has come together. And it's just the process of good intentions and everything coming together in a way that it truly must have been meant to be.
Yeah, I would just add that I'm sure everyone in this room can probably agree, and people watching this, everyone is affected by cancer. And it really takes the world rallying around the cause to hit it from all different angles. You know, there's a lot of great foundations that do research, research for pediatric cancer, research for all the different types of cancer, but there's also a lot of different foundations that are attacking it from just helping the family. You know, even in this last year, I come from a family of 8 boys, 1 girl, 9 kids. And my older brother this last year just lost his wife to cancer. It was 1 year of her diagnosis to her passing, and they have 7 kids. And so watching that process for me has just been a constant reminder of how important this work is that everyone is doing, and how many people it affects. And so I would just say that, you know, as musicians, we have a very, very selfish life. We really do. We get on stage, people laud us and applaud you, and then we put out this music, we get interviewed about our lives over and over, and so we really have done very little in what we could do. You know, it was like, here's a phone call to somebody who's intelligent about this. Hey, let us get on a stage and play some music, you know, at these galas and make a couple hospital visits and stuff. But really, the people that are not on this stage are the people who have done incredible amounts of work. And so I just want to say, we have an amazing team of people like Jeff who have sacrificed a lot more than we have.
To put pediatric cancer in perspective, it's relatively uncommon for kids. It makes up fewer than 1% of all cancer diagnoses, but it's still the leading cause of death by disease for kids past infancy, and obviously has a huge effect on the family and the parents. Ben, what are some of the big holes when it comes to funding and research for pediatric cancer, and how's the foundation trying to make up for that?
I mean, it's not all that uncommon. It's, I believe, 1 in 240 something kids will be, diagnosed with cancer, and it's a terrible thing. It's hard to, to be able to support a family and just like face life when you're dealing with this thing. And we just try to, provide a little bit of lightness. We try to take a little bit of weight off of the family. We try to step in there, pay the mortgage, pay the gas bills, everything that, it's filling in the holes for all the other programs. It's really obvious to say, you have a child that has cancer, you obviously need these medical bills, you have all these things that are directly related to the disease that you need to take care of. But that disease is not just, a medical hardship. It's a social hardship too. It's a hardship that the whole family has to go through, and we try to help lessen the blow that it takes outside of just the realm of the medical side of things.
It sounds like Tyler made such an impact on all of you. Dan, you talked about this a little bit, but are there any particular memories that you hold on to from him or moments with him that help kind of motivate you as you carry the foundation's work forward?
I think it comes back to sort of your question about, when we play for these kids. I think there's a common factor to all of them is they're just so resilient and so happy. Like, they all have so much energy and so much life in them. Like, these kids, like, I don't know what people expect when you go to a hospital where there's sick people and you go to this ward of the hospital and you don't know how the kids are going to be. Every single time, these kids are smiling, like the biggest smile you've ever seen in your life, every single time we go. And they're just so full of energy and life, and they have so much hope. That's kind of, Tyler was just like that. He was the epitome of that.
He was texting me the week before he passed. We had a show coming up, and I think it was in Utah, and at this point we were like playing arenas. And so he had watched kind of the ascent through the years, and he said, hey, I'm coming out to the show, and there's this girl that I really like. I was really hoping you could hook me up with a ticket. I did have cancer. It was like something to that extent.
He would do that.
Yeah. And so, our last text exchange was me telling him, that we were going to get him a ticket to the show, and it really was. That's the thing with cancer too, is it can be gone one moment and back the next moment. He was cancer-free that last week of life, and then it was just the cancer came back out of nowhere. It was like 2 days prior to him passing that they rediscovered that he had cancer. So it was just a roller coaster ride, and it's you know, there's a lot of, it's just devastating. I mean, there's really no other way to put it. It's devastating, especially with kids who are innocent and happy and smiling. And so our goal is to just do as much as we can to help alleviate some of that emotional distress and financial distress.
Daniel, you're in DC, sitting in front of a very influential audience, and there's a lot of talk about policy here and funding for cancer research. But as someone, coming from the opposite side of the country and with a completely different occupation than most people here, what would you want policymakers to know about pediatric cancer?
Yeah, I think we've already touched on a lot of it, but to reiterate, like pediatric cancer is not just a diagnosis for one child. It's like it hits the entire family, and like Ben was pointing out, sometimes you have to go out of state to see a specialist. Sometimes you have a very specific diet that's expensive. There's other kids in the families a lot of times that you have to care for. So this is not just an isolated one-person diagnosis. And it's not just something you can hit with medical bills being paid or extra treatment. There's so much more. It's so much more complicated. And consider donating to the Tyler Robinson Foundation or coming to our gala and getting a table this year is what I would say. Come join in the magic, and it's an experience you'll never forget, and hopefully you'll be very moved.
Yeah, and I think that even though we are really focused on trying to fill in those holes, there is so much going on with the technology and the progress in the treatment side of cancer and pediatric cancer. I think that the gene therapy is really, really interesting, and the more funding, the more eyes we can get on that. Hopefully someday pediatric cancer won't be a thing that's affecting people anymore. It won't be a thing we have to worry about, and we can shift over to a new cause. Who knows what other thing we could, but our biggest dream would be for the Tyler Robinson Foundation to not need to exist, I think.
Yeah.
Now, several of you are parents, right? Dan, you said you have a newborn, so congratulations.
Thank you. 2 weeks.
And Wayne, you have some children as well?
There's 7 children between the 4 of us, right?
And 2 of us account for all of them. Our wives account for all of them.
There are children.
Yeah. So, but how does working with kids who have cancer, how has that shifted your own perspective as a parent?
I mean, it's definitely a lot heavier. Not to say you can't appreciate children unless you have children or something. I haven't had children, but I have children. My wife has had children. And I will say that the thought of one of my, I have a 7-year-old, I have 2 twin-year-old girls, and then I have a 2-week-old little boy who was just born. And the thought of someone diagnosing one of my children with cancer, I don't know if I have a greater fear, honestly. I really feel like, when your child is hurt, to begin with, I've always struggled with self-love, so I feel like well, now I feel like this is a therapy session, but
That's okay.
So when my child is hurt, it's like this overwhelming, devastating feeling that I've never really felt in my entire life. If this person got hurt, I think everything would just kind of fall apart. I don't know.
I mean, all it really takes is just.
Why don't you answer this in a way that sounds less dark?
I think it just takes like a very small amount of empathy to really put yourself in the place, because, like Platt said, there's actually a third of families face like possible financial ruin when their kid goes through cancer. Like, I didn't know that, and so putting myself in that position of not only did you get the worst news of your entire life, also you might go bankrupt. It's like to have to battle those 2 fronts at the same time. To me, I mean, it just takes a slight bit of empathy to really be a cause that you can really get behind. So, I mean, I don't know. It's kind of a no-brainer.
Yeah, you were asking about when we were playing at the Steve Young Music Therapy Ward in Utah. You know, like when we went into that ward with the children and we passed out instruments and we were doing just acoustic songs and singing with these kids, it seemed to us like the kids were so excited that someone was coming in to pay attention to them in that moment, it was like, this is maybe the most important thing we've ever done, and anything that feels anything like this is something we're all about, and we were all hooked.
Dan, you do the songwriting. I understand most of the songwriting. I don't want to take credit away from anybody else.
We all write together, but just so there's no band fight, that we actually
Not
write
trying
the
to
songs.
create division.
No, we write the songs. Yeah, I just do the lyrics and melody.
Okay, got it. So that you had mentioned the song "It's Time" as something that Tyler really loved, but has this affected? Just thinking about pediatric cancer, has it affected you musically as you've been, coming up with ideas for songs or lyrics, or is there any way it's kind of changed or shifted your perspective in that?
Yeah,
regard?
I mean, I think just any sort of emotional drama in your life, or trauma or self-emotion, or people around you affects how you write. I've been affected absolutely by the time that we have spent around families who are really in a state of desperation, and I can't identify a song and say, well, this song was about this, because I don't really write that way. I kind of just write as a journal, and it's kind of just expression of how I'm feeling that day. But certainly on days, I think I write about a song every day, and so I've written songs on days that we've come home from hospitals with kids and who so absolutely but I couldn't. I've never written a song where I'm like, today I went to the hospital, and it's like,
ooh, wait, record that.
If you were country music singers, you probably would.
Yeah.
Not a bash on country music.
No, they're good at putting it on the nose. No, but yeah, so short answer, yes, absolutely. But I don't really, I couldn't identify a song for you.
Sure. If people want to get involved with the foundation, whether through volunteer work or donations, how might they do that?
trf.org is a great place to start. I will just throw out, just so people can understand, that it actually is more legit than the four of us kind of absolute eccentric looking people up here that aren't that well spoken. We've actually helped 10,000 families all around the world, raised nearly $10 million now as of this year. For House, many years we've been a foundation. That's pretty rad. We have a super awesome percentage of money that goes out versus
85%.
85, thank
on
you.
The dollar.
Which is, our manager, basically, we've kick him every single year to work extra so that we can do that. So thanks, Mac, who's also my brother. But I'm his boss, just a reminder. And so yeah, it's really legit and amazing. And I wish that we could be more eloquent in explaining all these wonderful people behind us that do all the real work. And we have this amazing board of accomplished people who have done this for a long time and do it.
And includes the Robinson family also on the board.
And so, long story short, trf.org, you can donate, and I can assure you that your money is going to an incredible cause, and yeah, not towards our terrible clothing.
There's only a minute left, and you have so many more cards. I'm sorry.
Oh yeah, sorry.
Oh,
Lightning round. Go.
Yeah, exactly. No, actually, we are out of time, but to your point, I want to thank Daniel Platzman, Ben McKee, and Dan Reynolds, and Wayne also for being our guests of honor this morning. And if you want to watch any of today's interviews on playback, please visit WashingtonPostLive.com, and there will also be a podcast version available as well. I'm Paige Winfield Cunningham, and thanks for watching, and please stay for our post-reception after the event. Thanks.
Thank you.